by some ER physicians that wanted to start contracting services to other emergency rooms. And now QuestCare is in the adult medicine hospitalist business, the pediatric hospitalist business, the intensivist business, the hospitalist surgery business, and the most recent addition was the OBGYN hospitalist business. I was in private practice just north of Houston in the Woodlands, Texas for 17 years, working in private practice in academic medicine. And I too decided there was a better thing than private practice out there. I was in solo practice, and so in late '07 I was asked to come to QuestCare to start the OBGYN hospitalist subsidiary for QuestCare. Our first contract was an HCA facility in Plano, Texas, which is a northern suburb of Dallas. And it's just grown since then. We're starting our 5th one soon and our 6th and 7th, hopefully by the end of the year. We have a model similar, I think everyone has a similar model. We do 12 and 24-hour staffing with our OB-GYN hospitalist. We started out initially in '08 doing just 24-hour shifts, and that's moved to now a model where we do 12 and 24-hour shifts, a combination of both, and the hospitals seem to really like that. The majority of their shifts are still 24-hour shifts. They're required to be a full-time employee with QuestCare to do the equivalent of 15 12-hour shifts per month. And they, like I say, they do those in combinations of 12s and 24s. We cover the malpractice. We have a health benefit plan and a short-term, long-term disability plan for our physicians. And we also have a partnership track for our business. So we're a little bit different. We're not just employing physicians, but we're kind of touting QuestCare as a new partnership, if you will, a new career for you beyond private practice. And so we have our entire company is structured that way. We have almost 400 physicians that work for QuestCare now. And every subsidiary of QuestCare is a partnership track, and it's just sweat equity. You work for us for 3 years as a full-time employee, as a full-time OB-GYN hospitalist, you become a partner in the company. But we do also have some PRN physicians as well that may work as little as 3 or 4 shifts a month at our facilities. The other thing that we do that's a little different, and a lot of this has come up and you've seen if you've been to Rob's website much, you run into some problems with what you can and can't do for the physicians, because in our situation, our contract is with the hospital. So we've contracted with the hospital to provide this service of OB-GYN hospitalist. So you're somewhat limited as what you can do for and with the private OB-GYNs in the facility. So we've created a kind of a different approach there. We have what's called a separate extended services agreement that we sign with the physicians that basically lets us act as somewhat of a call partner for the physicians on staff at the hospital, and then we bill the physician for those services so that they can still bill their global and collect their global reimbursement for that. And so it's something we've done. So it's been very successful and very attractive to the solo practitioners at the hospitals, or those physicians that are in a real small group, like maybe 1 to 2 people, and opens up us to be able to provide that service for them as well. And in addition, what I got? 1 minute. I'm doing good. In addition, we've also, you've got to offer, as an OB-GYN hospitalist group, or if you're starting a program, you really need to offer something that adds value to your program, I think, and that's what we've tried to do. The patient safety thing is great, but sometimes as CEOs, they're looking at the bottom line, and we all know that. And so we really work with the hospitals to try to determine what service lines they would like for us to grow and proliferate on their behalf, and we also help market that. And maternal transports is a big one. When outlying physicians in the community find out there's an easy way to transfer a patient, then that word's going to get around fast. And so if you can grow that business on behalf of the hospital, which then grows their NICU business, then you've really helped that hospital out from a financial standpoint. And then in one of our programs, we developed a service line which has been hugely successful at Medical City Dallas Hospital. It's a fetal anomaly care and treatment program where we deliver babies with congenital birth defects. And this year we're going to be delivering about 120 of those babies in that facility. And then that promoted us then to open an outpatient facility for those patients as well. So now we staff an outpatient facility at Medical City Dallas, which our hospitalists may or may not participate in if they want to. And so we have that as well. So that's kind of the way we're headed with stuff with QuestCare. And again, I'll be glad to visit with anybody afterwards. We'll hang around.
Thank you so much. Next is Alan Fishman.
Thank you for inviting me. I'm Alan Fishman. I'm a maternal fetal medicine doc, so I don't want you to feel infiltrated, but I'm not an OB hospitalist. I'm medical director of the maternal fetal group for obstetrics in San Jose, and I'm also the national director of clinical operations for obstetrics nationally. And really it started the first of the OB hospitalist programs within obstetrics. At this point we have 7 practices, 6 fully staffed practices, 1 that there's a single person starting working with the MFMs, and they're ramping that one up. Our practice went live with a hospitalist program January 1st, 2007 at Good Samaritan, which is primarily a private institution. But like what was just mentioned, we have a structure that not only do we cover walk-ins and unassigned, but we work with private groups and provide coverage. And so mirroring, if you think of it as mirroring what their coverage arrangements are with each other's, for the onesie twosies that work together and cover each other but aren't really in the same group, they have the opportunity to sign out coverage to our group, similar to what you described, having a contract, and we bill them directly. ACOG actually has a committee opinion talking about the structure and how you can structure that, and having to check with your state payers and your local payers, but we've kind of jumped through those hurdles and been able to do that successfully. One of the things that I'm particularly passionate about and very interested in, I really hope that as a group here we begin to sort of think about, is trying to sort of quantify what we do and quantify where the value add is. It's virtually impossible to say. We can all say, gee, this is way safer to have an OB. And for a decade I worked in my hospital saying it's lunacy that we have in-house neo and in-house anesthesia and no in-house OB. Who's going to start the section? It just doesn't make any sense. And so while we say it's quite intuitive, it's really incumbent upon us as this sort of first generation of OB hospitalist programs to be able to somehow document what it is we're doing. To say, gee, I didn't get sued doesn't help you. I mean, it helps you. It's how you can't prove what didn't happen. So as we think about that, and what are quality parameters that we can measure and track and look to sort of track in our practices as groups, one sort of soft metric that I have encouraged people that are OB hospitalists to try and do, and I've done as faithfully as I can in my practice, I have a file that I call my saves file, and I define a save as anytime any of our OB hospitalists do a C-section and deliver a baby before any other obstetrician is present, that I will put in the save file, regardless of outcome, because that is a section that would not have been delivered at that time if there wasn't. If another OB is there to help you, well, they could have started the section too. So I try and just sort of quantify that. And I'll tell you, at our volume, we have about 350 deliveries a month. I have about 2 a month that go into my saves file, and there's some good stories in there. So there's some good anecdotes and good stories. I don't know exactly how to quantify that. I don't know how to put this in a statistic and how we can publish this, but what I feel as we think about this, and one of the things that I'm struggling with, is how do we document what the quality indicators and what the patient safety parameters, how do we quantify the document that we do? Not just OB volume and not just, gee, I did this many deliveries or I billed this much, but what are the specifics that we're able to do? And I think the more we're able to do that, the more